Okay, I am going to start the webinar in 3, 2, and 1.
Hello, everyone. We are about to start, but I will give people to gather a few more minutes, a few more seconds, actually, and we will start shortly. All right, why don't we begin? Hello, welcome to the webinar report back from ASCO. What's the latest in metastatic breast cancer? I am Victoria Goldberg, and I have a script here that tells you how much I do at SHARE. Suffice it to say that I just run a metastatic support group and a metastatic helpline, and we also have a new podcast that we call Our MBC Live that's dedicated to metastatic patients, and it's created by us, people living with the metastatic disease. But before we start the presentation, I would like to tell you a few words about SHARE. SHARE is a nonprofit organization that has been helping people through breast, ovarian, and uterine cancer for the last 45 years. By offering the support of those who have been there. SHARE provides many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. For more information, please visit our website at sharecancersupport.org. All participants will be muted during the presentation. When Dr. Pluard finishes presenting, we will begin the Q&A discussion. You're welcome to submit questions during the presentation through the Q&A section at the bottom of your screen. The chat section will be disabled. When asking questions, please remember that the presenter is unable to get specific medical advice, so keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. So it's my distinct pleasure and honor to introduce to you our speaker, Dr. Timothy J. Pluard. He is a Paul J. Kuntz Endowed Chair in Breast Disease at the University of Missouri and Kansas City School of Medicine. He's also the director of St. Luke's Cancer Institute and the founder and director of the St. Luke's Kuntz Center for Advanced Breast Cancer. The Kuntz Center incorporates a unique multidisciplinary team dedicated exclusively to the comprehensive holistic care of patients with metastatic breast cancer. The center is heavily involved in research of new therapeutics for MBC, the psychosocial impact of MBC, and the physical functioning of patients with MBC. So please welcome Dr. Pluard to our webinar, and let's hear what happened at ASCO this year. Dr. Pluard, please.
Thank you, Victoria. Let me just share my screen and we'll get started. Okay, we should be. Okay. So I assume everyone can see the slides. So thank you all for joining, and I appreciate the opportunity from SHARE to be able to bring you some of the updates from ASCO this year. Going through ASCO is somewhat like going to the candy store. There's so much stuff there that you don't know where to start and, more importantly, where to stop. So I would show you the agenda for the evening. And this was an interesting ASCO where there wasn't, as we were talking before we got started here this evening, there wasn't really a stop the press study, but it was really an interesting, I thought, inflection point, because in part we were looking back at studies that previously had changed our standard of care, and now we're more mature, but we were able to learn a lot from some of the correlative work that went into those trials. And we'll talk some about that. But we also, I think, got to see a glimpse of some of the future with newer agents and newer strategies. And we'll go through that as well. So we'll start with the ER positive. And we did have a long-term follow-up on the outcome of the Paloma 3 trial. So just to refresh everyone's memory about Paloma 3, so this was a trial of fulvestrant and palbociclib compared to fulvestrant and a placebo in patients who had prior hormonal therapy. And it was a unique population because unlike most of the other CDK4/6 trials, which really looked at primarily chemotherapy naive patients, about a third of these patients had previous chemotherapy in the metastatic setting. So the long-term follow-up showed, which was very reassuring, at 6 years that the improvement in overall survival and a similar improvement in progression-free survival, which I didn't show for the sake of time. But you can see that the group in blue receiving fulvestrant and palbociclib, at about 18 months, you start to see a significant separation in the survival probabilities. And that actually increases and then maintains that, so that still at 6 years later, there's still a survival advantage. And it's fairly significant in terms of the absolute value. It's about 7 months in overall survival. And again, these are, patients who are very early in their treatment journey. So there are a lot of subsequent treatments that can occur after the fulvestrant and the palbociclib. So this was very reassuring. We'll talk a little bit more about some of the analyses that were looked at in various subgroups of patients. We talked about chemotherapy, and this is one of the analyses that I thought was very interesting. It looked at the outcome of that group of patients who had prior chemotherapy versus those that had not had prior chemotherapy. So the no chemotherapy group is on the left, which shows a very similar impact for the overall compared to the overall population. Whereas the group on the right, which is about a third of the patients in the study, had prior chemotherapy. And in that group of patients, there really didn't seem to be a difference between fulvestrant alone and fulvestrant with the addition of palbociclib. So this is, I think, potentially hypothesis generating, because you could speculate on the reasons why this might be. Perhaps those patients whose physician chose to give them chemotherapy early in the course of their hormone receptor positive disease felt that they had very aggressive disease or they had a high visceral disease burden. But it may also tell us something biologically, that those patients may have underlying genetic changes or molecular abnormalities within their particular tumor that makes them possibly unresponsive to palbociclib, but also unresponsive to chemotherapy. So we don't have any data to try and explain this, but I thought it was a very interesting observation. And I think one of the challenges that we've faced over the past years, and I think it's diminishing, is the early use of chemotherapy instead of endocrine therapy in patients who are ER positive. I mean, I think in general, unless there's visceral crisis, which is a subjective definition, but unless there is a visceral crisis, women with ER positive disease should always start on endocrine therapy. Number one, with the addition of the CDK4/6 inhibitors, it's very effective, and in some studies as effective as chemotherapy. And number two, it's certainly much less toxic, and the quality of life is better. So I think it is an ongoing education, the continued education, that the mere presence of metastatic disease in the liver does not necessarily equate to the fact that you should not have endocrine therapy. As long as you know that metastasis in the liver is still ER positive, then those patients are still good candidates for endocrine therapy and CDK4/6 specifically in first-line therapy. So switching over to MONALEESA-3, a similar study to Paloma, except with ribociclib. So this was a somewhat larger study comparing fulvestrant and ribociclib versus fulvestrant and placebo. No prior chemotherapy in this patient population, and they could have had only one prior endocrine therapy in the advanced disease. They could have had prior adjuvant therapy. And again, what we see is that the benefits that we saw and that were reported earlier are persisting and are quite substantial. And again, if you look at 5 years, there's a 15% or relative improvement of 50% overall survival in the patients receiving ribociclib. And again, I think this long-term data helps us to ensure that we're getting patients started on CDK4/6 inhibitors early in the course of their disease, ideally in first line. When the data first came out about the CDK4/6 inhibitors, and it was primarily based upon progression-free survival, and there was a lot of discussion about, well, do you have to start up front with the CDK4/6 inhibitor? Could you save it for later? I think that this is really compelling evidence that long-term, the benefit for starting early is persisting. And so I think it, in my mind at least, kind of settles that question. So these are the takeaways. So the improvements, as we said, are now well established. The second point I think is important, and I didn't go into it, but part of the MONALEESA presentation was looking at the time to progression on the second line treatment, because there's been some concern that once you use the CDK4/6 inhibitor in first or second line therapy, then subsequent therapies are less likely, endocrine-based therapies are less likely to be effective. And so when you combine both the progression-free interval on the CDK4/6 inhibitor with the progression-free interval on their second treatment, it clearly still favored utilizing, in that case, ribociclib up front. So the third point, which I actually didn't present in detail, was an analysis from Paloma 3, looking at the impact of various mutations on the efficacy of palbociclib in combination with fulvestrant. Specifically, they looked at the presence of ESR1 mutations, PIK3CA mutations, or P53. And almost half of the patients in Paloma 3 had mutations in ESR1. So it was very meaningful data. And what was found, and true in all three mutations, is yes, the presence of one of those mutations is prognostic in that the prognosis is less than if you had did not have the mutation. But the predictive value, and that is what is the probability that even with a mutation you're going to benefit from the treatment, in this case the CDK4/6 inhibitor, was still present despite the mutations. So even though the outcome with or without CDK4/6 inhibitor was below that of those without the mutations, they still benefited from the CDK4/6 compared to placebo or endocrine therapy alone. So I think that was very useful information to have. And we already talked about the lack of benefit from the chemotherapy. So I put this slide up here. It's very busy, but it basically is a schematic of the CDK4/6 pathway, right? So we think about the estrogen receptor and cyclin D and CDK4/6 controlling the growth of the cells. It's a checkpoint. So they control whether the cell goes into the growth phase of its life cycle. And so there was some data presented because we're trying to understand, what are the mechanisms by which these cells become resistant and the treatment loses its effectiveness. And it can be really one of two things, or one of two primary mechanisms. You can become resistant to the CDK4/6 inhibitor, or you can become resistant to the anti-estrogen agent that's in the combination. And obviously important to understand which of those it is in each individual patient if possible. And so we've already talked about some of the mutations in the estrogen pathway, ESR1, PI3 kinase, that can impact this. But we also mentioned P53. And then there was a number of studies looking at different signatures of resistance in this population. And I think there's somewhat of a convergence around this right here, the cyclin E and CDK2 as a primary mechanism of resistance to CDK4/6 inhibitors, because as you can see, they have the potential to directly impact the final step in the pathway. So there are inhibitors of CDK2 in development, and hopefully we will start to see these emerge into early stage clinical trials and hopefully to the clinic at some point. So this is just really a summary. Important to note, one of the things is that we had hoped is that perhaps the CDK4/6 inhibitors in combination with endocrine therapy would reduce the development of ESR1 mutations. But what was seen in the trials is that they are increased. So perhaps it slowed it, but it didn't eliminate the mutations in ESR1 as an escape mechanism for these tumors, even in the presence of CDK4/6 inhibitors. Okay, so now switching gears, to look forward. So we had some very interesting presentations about emerging endocrine agents. There's a class of oral SERDs, selective estrogen receptor degraders. Fulvestrant is the SERD that's clinically available right now, but as everyone knows, it's intramuscular injection monthly, and an oral SERD would certainly be desirable replacement or improvement. And so there are a number of them in development, and in testing and in clinical trials. We saw data on two of the SERDs, giredestrant and amcinestrant, and then a new class of drugs, SERCAs, called the selective estrogen receptor covalent antagonist. So H3B6545 presented data, which we'll talk about here in a minute. And then a second or new class really are the selective androgen receptor modulators. And enobarsim was presented as well. So this is data on giredestrant, and I'll just highlight, this was a patient population who had less than 2 lines of therapy in the metastatic setting, and they were testing various dosing levels. But if you look at the population, it's fairly early, although 2/3 of the patients that had CDK4/6 inhibitors, and almost half had ESR1 mutations. And if you just look, this is a waterfall plot, so it visually gives you a very almost instantaneous assessment. So the bars below are responses, and those moving above are progression. So you can see that there's a fairly good response rate in these patients who had previous endocrine therapy. So this shows a promise, and later, more later stage trials are already ongoing with giredestrant. It's very well tolerated. It was seen, activity was seen whether there were ESR1 mutations present, or they'd had prior endocrine chemotherapy or CDK4/6 inhibitors. And the dose that they elected to move forward with is 30 milligrams. So hopefully we'll be seeing more trial results with this agent moving forward. So H3B6545, so they presented a phase 2 expansion of their phase 1B trial. This is a population that was more heavily pretreated. They'd had a median of 3 prior therapies in metastatic disease. So this was really 4th line therapy with an endocrine agent. So including 62% of the patients having an ESR1 mutation. And you can see that 80% had had previous aromatase inhibitor, 84% CDK4/6 inhibitors, and over 70% fulvestrant, and 50% chemotherapy. So this is a fairly advanced patient population. Drugs seem to be fairly well tolerated, mild GI upset, a low incidence of anemia, and a rather unique toxicity to endocrine agents is that it can cause bradycardia, slowing of the heart rate, but was for the most part asymptomatic, and patients weren't aware of it or impacted by it. And these are the results that were presented, and you can see that in this population, again, that's on average 4th line therapy, that there was an overall response rate of 17%, and a clinical benefit rate of 1/3, and that's generally overall response, stable disease, for 6 months or 24 weeks. And the progression-free survival of 5.1 months is certainly encouraging for a late-line endocrine therapy where half the patients had previously had chemotherapy. And one of the more interesting observations is, since there were so many patients with ESR1 mutations, they were able to look at small subgroups. And the subgroup that had a clonal mutation Y537S, this specific mutation seemed to do better with H3B6545 than the population as a whole. Numbers are small, so it's hard to know how much to take from this, but it was compelling enough that the trial has been amended, and now we are enrolling a cohort specifically with this mutation. And there may be chemical properties of H3B which make it more effective in this specific mutation. But it also had activity in other ESR1 mutations that was similar to the group as a whole. So some encouraging results from this new class of drugs for sure. And then switching, lost my train of thought here. Oh, okay. So I'm switching gears here a little bit. So this is, we're switching kind of into HER2 mode. I've lost my section divider there. So, so this is a study that was presented from Chinese colleagues. This is UCC 02 trial. And this trial was asking the question of those patients who had ER positive, HER2 positive patients, comparing endocrine therapy to chemotherapy, with both in combination with trastuzumab. So at the time they did this study, pertuzumab was not available there. And basically they were asking the question, can we treat patients with endocrine therapy in combination with trastuzumab, as opposed to moving directly to cytotoxic therapy in the first line in combination with trastuzumab. And this is the progression-free survival. And interestingly enough, this is designed as a non-inferiority trial, which it failed to actually meet its primary endpoint. But you can see that the actual data suggests that the chemotherapy group was not clearly superior to the endocrine therapy group. And they didn't specify the precise endocrine therapy that was utilized. There was some discretion of the treating physician, but it was in combination with trastuzumab. And again, when they looked at overall survival, very similar for the endocrine therapy versus the chemotherapy in combination with trastuzumab. So the trial's limited because it didn't compare to the current standard of care, at least in the US, which would be trastuzumab, pertuzumab, and a taxane, docetaxel in the registration trial, which we know we have long-term follow-up that Dr. Swain presented at 7 years, showing that survival was still 37% of patients were still alive after that first-line therapy. So that's a pretty high bar. But I do think that this provides additional evidence that non-chemotherapy regimens are realistic treatment options in this population. You know, and if we take the data from Monarch-Her, which looked at the combination of fulvestrant, trastuzumab, and abemaciclib, one could ask the question about adding abemaciclib to the endocrine therapy to lead to even better outcome in that arm. But I think this really gets to that we need to personalize our treatments in shared decision with the patient, because certainly endocrine therapy is less toxic, and if patients are not terribly symptomatic or asymptomatic from their metastatic disease, perhaps a treatment regimen utilizing endocrine therapy with trastuzumab, which will have far less in the way of toxicity, would be preferable. And then reserving the chemotherapy regimens for later lines of therapy when necessary. Yes, sorry, my slides got mixed up a little bit. So I'm going back to endocrine therapy now, keeping everybody on their toes. So this really is all messed up. Feels like somebody shuffled the deck. We were talking about enobosarm, which is a selective androgen receptor modulator. And historically, androgens were widely used when we had very few endocrine agents beyond tamoxifen. They were widely used in the treatment of ER-positive breast cancer, but they're not very well tolerated because of the androgenic effects. So they kind of fell out of favor when aromatase inhibitors came into the clinic. So this is a new class of drugs that modulates the androgen receptor, but it doesn't have the same androgenic off-target effects, if you will, of hirsutism and some of the testosterone-related side effects. And so what they did is they looked at ER-positive patients, and they stained for androgen receptors, which are present in about 90% of ER-positive patients. And they used a cutoff of 40% staining and looked at the response rates based upon that. And you can see that for those patients who were above 40% AR staining, they had a 50% overall response rate, almost an 80% clinical benefit rate. So a really significant effect in these patients, all of whom had been previously pretreated with anti-estrogens. So the take-home message was that all the responses were seen in patients with ER-positive tumors. The cut point of 40% was considered optimal, and there now is a phase 3 randomized trial comparing enobosarm to exemestane in patients who progressed on a non-steroidal AI, anastrozole or letrozole, fulvestrant, and a CDK4/6 inhibitor. So I think this is going to be a very interesting trial because if what has been seen in the early trial is recapitulated, this may provide yet another anti-estrogen strategy to utilize before needing to go to chemotherapy. Okay. So now I'm switching to triple negative, if you will. So there was an exhaustive analysis of the tumor specimens that were obtained in the Impassion 130 trial. And I'm only going to talk about part of it, but it was a truly exhaustive analysis of the data. So just to remind everybody, Impassion 130 was comparing atezolizumab plus nab-paclitaxel versus Abraxane alone, nab-paclitaxel or Abraxane alone, looking at progression-free survival and overall survival in just over 900 patients. And again, if you look at the progression-free survival, there's a significant improvement of 1.5 months in progression-free survival. But more, I think, impressive was the 7.5 month improvement in overall survival in the patient population, again, who was PD-L1 positive based upon the SP142 assay. So one of the analyses they did was looking at the particular subtypes of triple negative breast cancer. We define triple negative breast cancer by what it's not, understanding that it's not a homogeneous group of tumors. And there have been a number of different categorization strategies. This is one that's based upon molecular subtypes and is kind of widely utilized. The 4 subtypes, so you have basal-like, which comprises the vast majority of triple negative breast cancer. And that can be broken down into basal-like immune activated versus basal-like immune suppressed. Then there's the LAR, the luminal androgen receptor. And then the smallest group, the mesenchymal group. And you can see here, which is very interesting, is that the expression of PD-L1 is much higher, or the number of patients with PD-L1 expression, I should say, is much higher in the subtype that's immune active, the basal subtype that's immune activated, versus the immune suppressed basal subtype and the others too. And so what is very interesting is that when you look at the PFS based upon the molecular subtype, you see here in the basal-like immune activated that there's clearly a significant difference in those patients who received atezolizumab than those who did not. There's a slight difference in this population, but really not nearly as significant, and really not much in the other groups. So, this potentially identifies a way that we can go beyond PD-L1 and potentially identify those patients who are most likely to benefit from at least atezolizumab in this trial. And this analysis may help also explain potential differences between trials because these relative populations could be potentially different between trials and might explain some of the somewhat conflicting outcomes, results that we saw with Impassion 131. So very interesting work there. The other, one of the other interesting analyses they did is they looked just at the presence of the CD8 T cells. Those are the effector T cells of the immune response. And so they characterized them as inflamed which meant the immune system was pretty much throughout the entire system, the CD8 cells, or they were excluded. They were there, but really on the outside of the tumor, or it was an immune desert. There were no T lymphocytes to be seen. And again, when you look within these specific subgroups in terms of their PD-L1 positivity, it's much higher in the inflamed group, still significant in the excluded group, but absent in the desert group for the most part, very small percentage. And again, how does that translate into the effect on patients? Well, as you can see, and probably expect, quite honestly, if it's inflamed, if your immune system is already there in place and actively working against the cancer, that adding PD-L1 is likely to provide significant benefit. Some benefit if the cells are there, but not actively into the tumor, and very little benefit, if any, when there are no immune cells present within the tumor. So again, a very interesting way of identifying or enriching for the patients who are most likely to benefit from these therapies. So just very briefly on sacituzumab in triple-negative breast cancer. So this sacituzumab was approved as third-line therapy in triple-negative breast cancer. It's an antibody drug conjugate targeting the TROP2 receptor on triple-negative breast cancer cells. And this was an analysis that was presented of the phase 3 ASCENT trial that was the confirmatory trial leading to its approval. And they looked at the 65 patients in the trial who relapsed early, less than 12 months after completing their neo or adjuvant chemotherapy, and had received only one prior treatment in the metastatic setting. So essentially, if you consider their adjuvant chemotherapy as a line of therapy, which we often do if they relapse less than 12 months after completion, you saw very interesting results and quite honestly, very similar to what was seen in third line, that compared to treatment chemotherapy of physician's choice, that sacituzumab had a much higher overall response rate, progression-free survival, and a more than doubling of the overall survival. So I think that this just highlights the need to be aware that in this population who has a relatively poor prognosis identified by their early relapse, that sacituzumab should be used earlier than their third metastatic line. Okay, now I'm going to finish up and close with just a few slides on HER2 low, which is really an emerging new breast cancer subtype that I think is going to have significant implications in our treatments for metastatic breast cancer moving forward. So, you know, we used to think of when we do HER2 testing, and this is a pathway for HER2 testing. It's initially done by immunohistochemistry, scored 0, 1, 2, or 3+. If it's 3+, you're HER2 positive clinically. If it's 2+, then you get FISH testing. And if that's positive, then you're positive. And we used to say that everything to the right of this is HER2 negative, and there was no benefit to HER2 targeted therapy. However, we now have some evidence that with newer antibody drug conjugates, that patients who are IHC 2+ and FISH negative or IHC 1+ may benefit from treatment with some of the HER2 targeting antibody drug conjugates. And so just so everyone understands a little bit about what we're talking about when we talk about antibody drug conjugates. So the concept is to take an antibody that recognizes an antigen on the cancer cell so that it will basically draw the antibody to the cancer cell. And then to that antibody is linked a payload, which is typically a cytotoxic drug. And so in the initial concept, the antigen would, or the antibody drug conjugate would bind the antigen on the cell, be internalized, then the linker here that is holding the drug payload to the antibody would be dissolved, the payload's released, and the chemotherapy is inside the cell and kills the cell. So that was really the first generation of antibody drug conjugates, and you can think of Kadcyla as the prototype for that. With improvements in technology, we've now been able to get more payloads. So 4 drug payloads is probably about what Kadcyla carries. Now, some of the newer antibody drug conjugates are carrying double that. So they're delivering more of a payload to the target. And also the linkers, the chemistry behind the linkers and what causes the release has changed. And so they can be hydrolyzable or cleavable, and they can actually be in the microenvironment of the tumor, which tends to be more acidic. There are some linkers that can be broken. And so that even if there are tumor cells that don't have the target antigen, they're killed by what we call a bystander effect. So, which can also happen when this cell dies and the payload is released out into the tumor microenvironment. So in terms of the HER2 ADCs, as I mentioned, Kadcyla was the prototype, which was, I think, approved 9 years ago or so. And HER2 has shown activity, as has the trastuzumab duocarmazine from Beyondis. So we know that and HER2 has already completed enrolling a phase 3 trial in HER2 low patients. And so hopefully those results will be forthcoming soon. And the TULIP phase 3 study with trastuzumab duocarmazine just reported their top line positive results in a press release right at the time of ASCO. So I suspect we'll see those this fall or at San Antonio. And then there are, quite honestly, multiple others, but there was data presented on 2 other HER2 antibody drug conjugates at ASCO, which I won't go into for the sake of time. But the impact of this is significant. So this is looking at the prevalence of HER2 low in various breast cancer subtypes, whether they're hormone receptor positive or hormone receptor negative. And you can see while the incidence varies and is highest in the hormone receptor positive, it's 50% of the non-HER2 amplified population is HER2 low. So that's a very sizable population of patients who could potentially benefit from HER2 low antibody drug, from HER2 targeted antibody drug conjugates if they are HER2 low. So this is, I think, we're going to be hearing a lot more about the HER2 low subgroup. So I will stop there and take questions.
Dr. Pluard, thank you so very much. This was fascinating. Thank you. I personally, and I'm sure everybody agrees with me, we have learned a lot. I mean, it's really exciting to hear about the low HER2 group, and absolutely amazing. The androgen finally is coming to its own, and there are all these new endocrine-related treatments available for the ER-positive group. I mean, it seems that the field is growing, and it's exciting. So thank you so very much. And we have lots and lots of questions, but not so much time. And if you still want to submit a question, please go ahead and do so. But we only have about 10 minutes and many, many questions. So let me start with the questions. So the biggest number of questions, of course, not surprisingly, was for the ER-positive group. And we've had people ask us to clarify a little bit about what you said about the Paloma trial results. So did you say that the chemo treatments and endocrine treatments versus starting with an endocrine treatment and a CDK4/6 inhibitor is just as beneficial, and there is really no reason to start with chemo as the first line of treatment?
So I would say in general, yes, you should start with CDK4/6 or endocrine treatment, unless there's impending visceral crisis. And everyone defines that differently. I have a very simple definition, and that is that if your first line treatment doesn't work, in visceral crisis, if your first line treatment doesn't work, you're not going to get a chance at a second line treatment. So that's a very small percentage of patients, in my mind.
Thank you. Thank you so much. All right, so related to that, the endocrine treatments, there are 3 CDK4/6 inhibitors, and it seems that there was another CDK4/6 inhibitor trial that was announced at ASCO. I don't know if you can comment on the fourth CDK4/6 inhibitor.
Yes, there was a presentation on dinaciclib, which is a new CDK4/6 inhibitor. I didn't see, a whole lot in the study that differentiated it from our existing CDK4/6 inhibitors in any substantial way. So I think we'll have to see if it turns out to be more effective. But I didn't see anything that jumped out at me as being more or distinctive.
Thank you. Thank you. So there was a question, and that question is asked all the time. There are 3 CDK for the purpose of our discussion. There are 3 CDK4/6 inhibitors. Do you have a preference to which one to start with?
I think it quite honestly, I think they're all similarly effective. I think you could, you pick on you select based upon the individual patient. So certainly I think we have very good data with ribociclib in premenopausal patients for its effectiveness there. That was really the only trial specifically looking at that population. So in that group, I utilize ribociclib for that reason. But beyond that, I think there are multiple clinical factors which weigh into which agent you choose, because they do have somewhat differing side effects.
Thank you. Another question that's been asked a lot and is asked here as well. Do you sequence the CDK4/6 inhibitors, or do you think there is any potential benefit in sequencing CDK4/6 inhibitors if you progress on one of them?
So the honest answer is yes, I do sequence them sometimes. I will also utilize abemaciclib as a single agent in patients who've progressed on either ribociclib or palbociclib. But the honest answer is we don't have data to really answer that at this point. So good, solid data.
Then a related question. Once you progress on a CDK4/6 inhibitor, what do you usually do in the clinic? What is the next line of treatment after that?
A clinical trial. Always.
An oral SERDs would be a good one, you think, to start with?
Yes, absolutely. Well, I think at that point, you really want to understand what the mutational landscape is, either with a biopsy or a liquid biopsy. Because if you have a PI3 kinase mutation, then certainly alpelisib would be appropriate. Or if you had a HER2 kinase domain mutation, then utilizing neratinib would be useful. So I think again, we need to start individualizing our treatment decisions.
Thank you so much. So another question, and another group of questions that people are asking, not surprisingly, about the low HER2. So people are asking, how do you get tested for HER2? Do you change from your initial diagnosis? Can you develop it as a somatic change once your cancer progresses, or is it something that you will be with from the beginning? And does it make sense to retest yourself from time to time about your HER2 status?
Yeah, so that's a great question. So let me start by saying, we need to be clear that low HER2 is not the same as HER2 positive, right? So in the classic definition of HER2 positive disease, there's amplification of the gene for HER2. That's the mechanism. And that leads to, instead of 100 copies of HER2 on a cell, to thousands or hundreds of thousands of copies. So those are not part of the HER2 low group. But those patients who are HER2 low show some evidence of HER2 protein by immunohistochemistry. And so you can change back and forth. And actually, they showed some data that if you look at subsequent biopsies over time, that there is about a 15% shift between being HER2 negative and HER2 low, both directions. So some who are HER2 low become HER2 negative, some who are HER2 negative become HER2 low. So I would say, yes, there is value in retesting. Right now, it's standard immunohistochemistry, like we always test for HER2.
Thank you very much. So we only have, I think, time for maybe 2 questions. And as I told you before the webinar began, that there would be a question about vaccine, and of course there is one. Do you think there is going to be a vaccine for breast cancer in our future?
I think that is a potential possibility. It may not be a vaccine in the classical sense of what we think, but it may be a way to kind of stimulate your immune system to attack the cancer cell.
Thank you. And I'm going to ask one question from me. I'm going to take this opportunity and ask you a question. So do you think there is a potential for a cure in some future? And how would you define a cure for breast cancer?
Well, I think, a cure, in my mind, my definition would be no sign of disease and no symptoms of disease. And do I think it's possible? I do. I think ultimately that's going to require the immune system.
So you believe that immunotherapy is the future?
I think manipulating the immune system is going to be a necessary component of any cure.
Well, thank you so much. This is an interesting answer, actually. This is the first time I've heard that answer, and I think it's fascinating. Thank you so very much. This was an amazingly good discussion. I'm sorry we only have 1 hour. I wish we had a lot more, but we so appreciate you coming, and thank you. Thank you so much again.
My pleasure. Thanks everyone for joining.
Take care. Thank you. Bye-bye.
Have a good night.